Hi, and good afternoon, everyone. Thank you for joining us for the Ohio AAP Preventative Health Program training. This training will be on vaping. Just a few housekeeping items. Please make sure your lines are muted and your cameras are off. There will be one CME and one MOC Part 2 credit available for this training, and the survey will be sent out tomorrow. The next training will be on 5 screening tools used in pediatric practice on September 9th at 12 p.m. We'll have new resources available. Excuse me, I'm sorry. Whew. We have new resources available, and our quality improvement project will launch in December. And we want to thank the Ohio Department of Health for their support with this project. This is a flyer with all of the trainings coming up. And then for our quality improvement project, it kicks off in December of 2022. It is a 9-month project where practices get to choose which screening tools they would like to measure. And if everyone could please make sure their lines are muted. Thank you. And we will have free resources available for everyone that participates, as well as 25 MOC Part 4 credits. And then each practice will receive a cash incentive for participating. There'll also be a post-evaluation survey sent out after this training tomorrow. Please complete the 98-day action plan, and then we'll be following up in 90 days. We'll have 2 speakers for this training, Dr. Mike Gittleman and Dr. Grace Paul. I will now pass it over to Dr. Gittleman, who's the medical director of the Ohio AAP Smoke-Free Families Program.
Thanks, Alex. And I'm fortunate to get to speak with you about kind of adolescent vaping 101. So my name is Mike Gittleman. I am an ER physician at Cincinnati Children's Hospital, and I run a lot of the injury prevention programs for the chapter, but I also run the Smoke-Free Families program. And so I'm going to talk to you about vaping today. Next slide. The presenters have really no financial relationships to disclose, and there's no conflicts of interest. Next slide. So today we're going to be talking about vaping, and I'm just going to go over kind of some numbers, some of the medical effects, and kind of what's going on to combat it. And then Dr. Paul is going to talk about some cases and kind of give you some real life examples. Next slide. So when I started to give this talk, I was like, it seems obvious what vaping is, but I figured it's always good to kind of start with, you know, what is vaping? And really, it's using a technical name, which is an electronic nicotine delivery system. And it encompasses pens, pods, tanks, electronic cigarettes. And what they use is they use aerosolized vapor, and they don't use smoke. Now, if you take a look in the upper right corner, it basically shows you what some of these devices, some of the things that they have. So many of them have a mouthpiece. They have some sort of cartridge, and that cartridge consists of a liquid, which has kind of the nicotine and what's going to be vaporized. They have some type of, or many devices have a switch, which will activate the heating element. There's a heating system, and then there's a battery on it. And the amount of nicotine in these cigarettes, they vary between brands and delivery methods. And many of these devices are also used for other things, such as marijuana. Next slide. So R.J. Reynolds had a nice saying that said, if a man has never smoked by the age of 18, the odds are 3 to 1. If he never smoked by age 24, the odds are about 20 to 1. So being able to hold kids off of smoking to later ages makes it so they won't smoke and have some of these problematic effects later. Next slide. So when you take a look at the National Youth Tobacco Survey, we see that more than 5 million US middle and high school students used e-cigarettes in the past 30 days. But what's really interesting is if you take a look at cigarettes, the cigarette use is slowly declined. And, many hear about the bad effects of cigarettes, and that's why many have started to not smoke. And also there's been laws passed where you have to be older ages to be able to get these cigarettes. But look at the e-cigarettes. They have gone up significantly, and there's close to about 27.5% of teens are using e-cigarettes right now. So this number continues to climb, and we'll talk more about it as we get through this talk. Next slide. And one of the problems is once you get started, many continue. So it shows that about 2 in 5 that use e-cigarettes frequently. And so that's greater than 20 days in the past 30 days. But 1 in 4 use these daily. And we'll talk about kind of why some kids start, but once they start, they continue to use them. Next slide. So what is their preferred method? So as I told you that vaping, the electronic cigarettes are made up of many different kinds. So you want to hit the next slide button? The most commonly used one are the disposables, where a child gets these devices. Sometimes all you have to do is inhale and the vapor comes in. And then after they're done with all of the liquid, they're just disposable. That's the most commonly used device. Next slide. The iPods and Juuls, those are the next most common. And we'll talk a little bit more about Juuls, but more than about a quarter of the time, Juuls are being used. Next one. And then many of them use a tank device too. You'll see people like that have this big device. Those are typically the tank devices where they kind of hold a chamber and then they'll smoke out of it. All right, next slide. So what do these things cost? It's interesting because, people say, oh, cigarettes are so expensive. But if you take a look, a chronic user of an e-cigarette compared to smoking a pack of cigarettes a day, they're about the same. It's about $5,000 per year that people are spending on these. But the median cost for a regular e-cigarette user is about $50 to $75 per month. Could be up to about $250 per month. So these kids are spending significant amounts of money on these devices. What's really unfortunate is in 2023, it's predicted that the e-cigarette and vape product sales are going to be close to about $40 billion. So the industry is making huge amounts of money on the sales to especially teenagers. Next slide. And unfortunately, youth are vulnerable, but particular youth are more vulnerable. So children with LGBTQ, they have an increased use of these devices compared to their heterosexual peers. The African-American youth actually don't use these devices as much as white and Hispanic peers, but the African-Americans more commonly use menthol products. The menthol product is more palatable and flavorable, but so is when you add the flavors to the electronic cigarettes, they are as well. Native American youth have the highest current nicotine use. Hispanic youth have a higher use compared to white and African-American teens. But the one I want you to concentrate on is the kids with mental health conditions. So think of how many kids now have been diagnosed with ADHD, depression, anxiety. This type of kid is using these electronic cigarettes more often, and they're using it to combat some of their anxiety and depression. But as we have more kids diagnosed with it, more of these kids are using these products. And these are the kids that are going to get more addicted later on, and we'll talk more about that. Next slide. When you take a look at how much nicotine do these products have? So it's looked at 1 Juul pod is about 20 cigarettes. And 1 pack of cigarettes, which is 20 cigarettes, is about 200 puffs. So if you've ever watched a kid, just like outside of a store, and you watch someone hitting one of these e-cigarettes, they'll take 5, 6 puffs, and then maybe about 10 minutes later, take another 5 or 6 puffs. So if you think about that, boy, they can easily smoke more than a pack of cigarettes a day just by smoking and taking puffs on these e-cigarettes. And each of these products have different amounts, but as you can see, the bars and the pods, they have, you need more puffs, so they're not as strong. The Juul is one of the strongest nicotine deliveries. Next slide. Well, how much nicotine do you get? Well, a lot of it depends on the bioavailability per puff. It can depend on the temperature, It could depend on how much liquid they use, the size of the droplets, the depth of the puff, the concentration of the e-liquid. The thing that's interesting is, though, Juuls and vape juices, even the ones that say there's no nicotine, they usually do contain nicotine. And a lot of time, it's a lot of nicotine that they're using. In addition, that there's the different kinds. So as I said, like if there's a free base, such as the e-juice or the tanker pods, they have higher pHs, which is harsher tasting, but they don't have as much of a nicotine per puff. As opposed to the Juuls, which have a lower pH, less harsh tasting, there's more lung absorption. Next slide. And so you sit there and many kids say, it's water vapor, I'm fine. Or maybe there's a little nicotine, but I'm not that worried about it. But there's a lot of other ingredients that are going into your lungs, such as there's volatile organic compounds, there's ultrafine particulate matter, there's the nicotine, there's some cancer-causing chemicals. So the propylene glycol mixing with heat can cause formaldehyde. There's heavy metals such as nickel, tin, and lead. And then the flavor can also cause severe lung damage. And I think that Dr. Paul is going to talk about that when she goes through her slides. Next slide. And one of the problems is the flavor makes them a significant draw. So, you know, flavors are designed to be the hook. These industries that are making $40 billion a year, they know exactly what they're doing. They give a little hook to say, it's not that bad. All it is water vapor. You'll be fine. They taste it. It tastes good. And then the nicotine comes in. There becomes a need. But nearly 85% use the flavored e-cigarettes because they like the different flavors. There's watermelon. I mean, some of them taste like candy. And so they start by using this. And then after a while, what happens is they get addicted and they get hooked to it. Next slide. See, initially, the e-cigarettes were viewed as a light cigarette. In fact, a lot of smokers thought, hey, look, it has better flavor, it's less harsh, and maybe it's a way for me to quit smoking. But what happened over the years, vaping users started to become younger, and these individuals started to get addicted to it and then have the nicotine. When they actually asked teens why they vaped, you know, more than 60% said they just wanted to see what it's like. So they see what it's like, they kind of like the flavor, and then they get addicted. Others say they like how it tastes. Some just do it as a social activity. Some do it to relax. Some like they feel good or get high. I mean, some of these devices, they might have nicotine, but also have some THC in them. Some say they're bored, but you know, what's scary is they want to see what it's like. It's a social activity. I like how it tastes, and they don't realize that they're going to become addicted to these devices. Next slide. So now I'm going to talk a little bit about some of the effects that happen to you. Next slide. So unfortunately, if kids use these vaping devices, you're 4 times more likely then to use cigarettes. So adolescents that vape are likely to use cigarettes. They're likely to move on to marijuana. They're likely to binge drink or use illicit drugs. And so some youth have higher risks. These are the untreated mood disorders or ADHD, the adverse child experience kids. So if you think about it, you've got a kid with anxiety. They're anxious about taking medication. And so why not take this if it calms them down? And then once they start doing it, not only do they get addicted, but they have that calming effect. It's really hard for them to quit. Next slide. And so kids their deck is stacked against them. So you've got the tobacco industry that's saying it's water vapor, don't worry about it. And here, it tastes good. Here's some flavors. The e-cigarette ads, 4 in 5 US middle and high school students have seen them. So these ads are going right towards kids. And then you get into that nicotine addiction cycle where your brain releases the neurotransmitter, you get nicotine blood levels fall, then your mind says, I need to take it more. And so then they ingest more nicotine. And it's a vicious cycle that these youth get caught up in. Next slide. And so these youth, not only are they getting nicotine just as an adult, but they're more sensitive to the addictive properties because their brain is still developing. So they get dependence at a lower level of nicotine use. in most susceptible within 1 to 2 days of their first use are already now becoming dependent on the nicotine. And they also have higher risk for withdrawal symptoms when they have a lower use. So before reaching levels of about 2 cigarettes per day, they can also start to have withdrawal symptoms. Next slide. And so what happens? What are some of the health effects? Well, vaping may be healthier than cigarettes, but by no means is it healthy. As I said, they have nicotine, they have these other additive properties, such as carcinogens, such as heavy metals. And unfortunately, there's about 2,800 hospitalized cases of serious lung injury associated with vaping products and about 68 deaths annually. We see nearly about 5,000 children, less than 5, that received ER treatment for e-cigarette or e-liquid nicotine exposure between 2013 and 2017. And we'll talk about how they've combated it. And more recently, they've done some research on mice, and they found if a mouse is using e-cigarettes for more than 54 weeks, close to about a quarter developed lung cancer, and almost half developed some bladder problems. And the other effects are hypertension, heart disease, gum inflammation, lung disease, severe lung injury, and the nicotine can worsen these anxieties and mood swings and irritability. So these things are anything but safe. Next slide. So when you hear that these devices are safer, it doesn't mean they're safe in any means. And when you hear teenagers say it's just water vapor, it's clearly not. And it's important for us to understand that when we're discussing the effects with teenagers. Next slide. Then my last 2 slides are, I'm going to talk, next slide. One is that, look, I think we're making some progress. So if you take a look at education and what youth feel about e-cigarettes and cigarettes, if you take a look, cigarettes, hookahs, nothing's really changed in their beliefs of that they're little harm or no harm. But if you look at e-cigarettes, more and more people are starting to understand that they're harmful at younger ages, which is important because our education is working, but we need to continue. Next slide. And I think that some of the areas where we're helping with the education is through legislative efforts. And I think that we're making some landmark strides. So in 2016, they began to regulate e-cigarettes. Before that even occurred, they were just sold almost like as organic, natural items where they weren't regulated at all. In 2016, they put together the Child Nicotine Poisoning Prevention Act, which was really important because, as I showed you, in 2013 to 2017, we had a significant number of kids that were getting involved with the liquid nicotine. They were finding liquid nicotine on the shelf, they would drink it, and they had nicotine exposure and toxicity. We even had a couple deaths as a result. So that caused them to make sure that the packaging had to be a certain way. Then in 2019, they raised the minimum legal sales age. So they went from 18 to 21. And you remember one of the first slides that I showed you is if you can get people to smoke at older ages, they're less likely to start smoking. So by raising the age makes it harder for them to get to it. And then in the FDA, as you might know, in 2022, they pulled Juul off the market because concerns about toxicity data. And this is only the national legislation, but there's also state legislation where they're looking at age regulations, banning flavors, taxing e-cigarettes to increase the cost. So we are making strides. And at the end of this talk, when Dr. Paul's done, we'll even talk about some resources that are available to you that you can use in your practice. I will now turn it over to Dr. Paul for some cases. And at the end, we can answer some questions.
All right.
Hi, everyone. I'm Grace Paul. I'm one of the pulmonary physicians at Nationwide Children's Hospital. And I've been here for about 10 years, and I got involved with talking about vaping and actually teaching at schools about vaping for the past 2-3 years. And I really enjoy that part of it. And I'm going to be talking about some of the EVALI cases and the complicated cases that we see here. I'm trying to open my slides now, 1 second. Are you guys able to see my slides or not yet?
Not yet.
Okay.
Oh,
Now?
there we go. Yes.
Okay.
I just need to filter to your, yeah, there we go.
Okay, is it okay?
Yes, looks great.
Oh, okay. So I'm going to be talking about EVALI. EVALI stands for e-cigarette or vaping product use associated lung injury. And what I wanted to highlight is these are like kids who did not have any underlying lung disease. They were pretty healthy without any major asthma or chronic lung disease, and how they ended up with severe pulmonary disease related to their vape use. What I find most scary about this product is that it is so unpredictable, and the effect of these harmful chemicals can be quite rapid. And unlike chronic tobacco smoke, like with a traditional cigarette, the vape devices and the chemicals, and also like heating up just the metal coil, the chemicals that are released can be quite toxic to the lungs. And so some patients, nothing may happen. And in some kids, even like a few days of use can result in severe lung damage. So what exactly happens with EVALI? So when somebody inhales a substance, it depends on the size of the particle, how much they inhaled, and where the product actually gets deposited. So if you look at the major airways and the trachea and the bronchi, so what we see is sort of new onset of asthma-like symptoms. So there is airway hyperreactivity, there is more airway resistance. The second thing that happens is there is a change in your airway immunity. So it's change in your host defense. So basically there is downregulation of even the genes that are contributing to which make the cells for improving immunity. There is decreased antimicrobial activity and increased resistance to bacteria. The third part is there is also, like, as the products go, as the particles go distally into the smaller alveoli, there is there are issues with decreased alveolar development. So we know that lung development continues until teenage years. So the number of alveoli sort of stops by around 5-6 years, but the size of the alveoli continues to increase into adulthood. So if we are like introducing all these harmful chemicals, that does stunt proper alveolar development. And on an immune level or on a cellular level, there is increased levels of necrosis and cytotoxicity. So I'm going to talk about a few patients, and these cases mostly were seen at Nationwide Children's, and a few I actually got from published reports. So our first patient, she's a 16-year-old girl. She has a history of anxiety disorder, and she presents with some cough, shortness of breath, abdominal pain, and nausea for 5 days. And she's not in distress. She does have bilateral crackles. And what was interesting was her basic cell count had peripheral eosinophilia of 24%. So normal eosinophil count is 1 to 4%, and her absolute eosinophil count was also high. She was just had mild metabolic acidosis, but other than that, her LFTs were fine. And then her inflammatory markers were also okay. So we were like, what is going on? And then we got her x-ray. So these are some of it is normal markings, a little bit of exaggeration. You can see here more paler, opaque, and in this area also. And So initial workup was we tested for with a viral swab or a culture from her sputum, a fungal, bacterial, mycoplasma, everything was negative. So at the time we treated her as just, okay, possibly viral, some maybe non-infectious pneumonitis, something has irritated her airway. And she was actually treated with ceftriaxone and clarithromycin even before presenting to Nationwide. So what I wanted to focus on was her pulmonary function test. So this is a pattern that we do see with our kids who vape. So you may be familiar with some of the PFTs that we check. So one of the numbers we're looking at is this FEV1, which is the forced expiratory volume in 1 second. So these numbers here, as you see, should be above 80. So you can see that overall she's fine. And then when we look at the smaller airways, that number is small, like less than 80. And then this is the curve, the blue line. And then when we gave her some 2 puffs of albuterol, you can see the response. So there was a 12% increase in her FEV1, which represents the main airways. And then the 25-75 is your small distal airway. So sorry, this should have been here, the 39. So we expect a 10% change or a 30% change, which indicates like a airway reactivity or response to albuterol. So this was a new finding for this girl. So her diagnosis was, okay, maybe this is some viral related airway reactivity showing obstructive defect with significant bronchodilator response. And she was started on some albuterol and Asthmanex. So she comes back a couple of months later, now with cough, shortness of breath, more chest pain, and she's been using albuterol at least 10 times a day. Her X-ray, she was diagnosed to have left lobar lobe pneumonia, started on azithromycin, but now you can see her clinical exam is worse. She's more tachypnic, decreased breath sounds, her saturations are lower, and her respiratory rate is also high. And she was started on, she needed oxygen this time, and then we did use our asthma therapies and gave her nebulizer burst, and she didn't really respond. Her diagnostics, again, labs showed eosinophilia, this time with the increased inflammatory markers. And she was in distress. There were some cardiac changes also. But interestingly, all her cultures were negative. So pulmonary was involved at this time. And the first thing we got was, hey, do you vape? And then she disclosed that she had been vaping for 1 year using Juul products with a non-branded mint flavored cartridges. And then she was also exposed to secondhand vape through her boyfriend. So this is her imaging. As you can see, her CTs, you can see obviously it's not normal. And you see all these like opacities here. This is like the multifocal pneumonia, ground glass opacities, some nodules that you are seeing, and then also these lymph nodes, enlarged lymph nodes here in the mediastinum. So here also you can see all this abnormal features. So she was diagnosed to have multifocal pneumonia. And then because she was not really getting, she was still needing oxygen and we were not able to wean, our team ended up doing a bronchoscopy. So doing a bronch is not common. It's not like the usual route to every kid who comes in vaping. But her case of this, why is she having peripheral eosinophilia? Why is she having all this respiratory distress? Still hypoxemic, instead of even after we gave her antibiotics. So what you can see is, you know, in her bronch, there's some like mild mucus, like mucopurulent secretions, doesn't look too bad. But then when we did the cytology, you can see again, pulmonary eosinophilia, like these cells here that you can see here, which is again, it should be less than 10 and hers was 62%. And then this is the Charcot-Leyden crystals that we talk about. We really don't see that so often, but in her case specifically, she had this like pink matter here. And so this time her diagnosis was more of a hypersensitivity pneumonitis or acute eosinophilic pneumonia, secondary to vape products. So our treatment at this time changed from doing antibiotics to doing systemic steroids. So within 24 hours, the patient was successfully weaned off oxygen and she was discharged from the hospital. She was sent home on a 2-week course of steroids and then a prolonged taper. And then in her follow-up, her PFTs were fine and her exam was also normal. So then this is just a graph of her peripheral eosinophilia. So, peripheral, we said 1 to 4%. So you can see when she presented earlier, like this was in 2017, it was fine. And then it went up to like 30s. She came back again, it was sort of okay. And then she went up to the 60%, 50+%. And then this is post, after treatment, after all our counseling, her number was better. So our patient did fine, and then she was lost to follow-up for some time. Before I go back to our patient, just wanted to show you this one. This is not our patient, but I got it from one of the publications on the impact of steroids. So when this is an EVALI patient, you can see the amount of infiltrates at the initial presentation. So these two correspond. And then this patient got worse, and you can see how much the lungs are affected bilaterally. And then this is post-steroid treatment. So again, it does not go back to fully normal, but significant improvement with steroids. So going back to our patient, she comes back after 1.5 years. And at this time, she's 19 years old, she's pregnant. And she gives us the history that she has resumed e-cigarette use since the last visit. So all our counseling just went down the drain after a brief break. And she was also exposed to passive smoke, tobacco and vape smoke. And she's telling us, yes, I stopped as soon as I found out I was pregnant, but is the damage already done? That was our worry. So as part of the same case, so what are the risks of in utero cigarette exposure to the infant? What happens? Because once the baby is born, again, the baby is already vulnerable right now. So what exactly happens in utero? So nicotine crosses the placental barrier, and the two big things it causes is oxidative stress, a lot of inflammation, compromises placental function, and therefore you are ending up with a much higher risk of SGA babies. So almost like an 8-time higher risk for SGA babies. And these babies have had, there are multiple reports showing that there is problems with the lungs, the neurocognitive issues, they have behavioral issues, anxiety and hyperactivity, which we do see in our clinics. And then they also noticed some cerebrovascular dysfunction among mice models. So when they looked at specifically mint flavored Juul exposure in mice, they saw that there was impaired lung development and increased risk for allergic asthma in the offspring mice. So this one, I know it's a basic science slide, but I thought it was very interesting what they did. So here they have control mice, e-cigarettes without nicotine, and this is e-cigarette exposure with nicotine, and what happens to the baby mice. And they looked at the molecular stage, the anatomic sections, and also function. So you can just see, just looking at it, this one size seems smaller. And then when you look at the alveoli compared to the control, you can see it's a little bit more erratic pattern. It's not really like a good alveolar structure. And then they had all these physiologic counts on, how much alveolar count is there. So you can just looking at this, the number of alveoli is low, the lung to body ratio is low, lung volume is low. So this clearly affects the baby in utero. And so when the baby is born, has a lot of risks for viral infections, BPD sort of features. So there's a lot more work that needs to be done on e-cigarette related in utero exposure, what happens, but it's just for you to know that if you ever see, we deal with adolescents, so the risk with pregnancy is high, not only for them, but also for their kids. So that was my first patient. The second one I'm going to talk about is, in our pulmonary clinic, we see a lot of CF, cystic fibrosis. So this patient had this very unusual mutation, and which is not really treatable with our latest medications. So that medicine is called Trikafta, which really takes care of a lot of CF-related gene modulation. So this patient does not qualify for that. But she had very good, generally her pulmonary status was good. She had clear lungs, normal PFTs. She had a lot of GI issues, and chest x-rays were stable. So because of all her GI issues, we had a lot of discussions on this, and we were able to get her off-label Trikafta. So as you know, Trikafta or these CF medications are around $300,000 per patient per year. Okay, so they are so expensive, and it was very hard to get it for her, and we got it for her after a lot of prior authorizations and phone calls and stuff like that. She was doing fine, and then she, she's a girl who had normal lungs, and then suddenly she started having all this persistent cough, congestion, shortness of breath, reduced exercise tolerance. She used to play volleyball. She's not able to do that. And so, initially, our initial thing is, does she have like a CF exacerbation? What is happening? She's on Trikafta. She had normal lungs. It should be only getting better, not worse. And then, so we were treating her with outpatient antibiotics. Then we admitted her twice, got her IV antibiotics, and then we couldn't figure out what was going on. And then she also had this unexplained weight loss. So here it's, this is her trend of pulmonary function. So you can see, it's pretty good. Like her lung function is around 100%. And then this is a phase we were like, what is going on here, even when she's on medicines. And then you can see her growth chart, like weight loss, like down and up and down and up. So it's a very concerning growth chart for our as CF physicians, right? Like, why is this happening? And here you can see this X-ray. It's not very obvious, but then post retrocardiac, there is like some haziness here. You can see it here also for a person who didn't really have any lung disease. So then she comes up, and then, we find out that she has been vaping, and we blame it all on vaping. But now it's to prove to the family, because the family was like, absolutely, this is not possible. And so we putting this unusual, like her demographics, this unusual group of symptoms, this weight loss, X-ray changes. So we decided, with parental permission, we decided to get serum nicotine and cotinine levels. So I wanted to just show on, like, when we get a report, how do we interpret this? So this is what I wanted to talk about, because this was a new learning thing for me also. So normally our serum nicotine should be less than 2 nanograms per ml. And this serum cotinine is a major metabolite of nicotine. And this is the 3-hydroxy is the next step. Because all of them should be like less than 2. And our patient, she denied using. So when we look at these numbers, you can see just serum nicotine, it was normal. So that means she did not use it like that day or in the like couple of days prior. But then when we checked at serum cotinine levels, this was extremely high. And so that means she had used it within 1 week of sample collection. So that itself was like, come on, you haven't been giving us, haven't been telling us the truth. And then when we got this number also, you can see it is 42 nanograms, which indicates a longer use. So this sort of fit in with her, like a temporal correlation of why her PFTs were lower, why she was losing weight. And so then we were able to like give the family objective information. This has been going on for some time. We need to do something about it. So it was a lot of time from our part, counseling, and a great collaborative effort with her school counselor and local counselor, which really helped. And then in her follow-up testing, she's been fine and improved clinical PFTs and her weight. And then in a lab research standpoint, they have said specifically that this specific chemical, the 2,5-dimethyl, affects your CF, the protein, and it causes problems with your airway surface liquid. And that's a big problem with CF. And so that's been like proven in the lab also. Okay, so my third case is a patient, 16-year-old with no significant past history. And then just to remember the time, this was May of 2020. So now he comes in with fever for 4 days, cough, a lot of shortness of breath, abdominal pain, nausea, and vomiting. And he's in distress, febrile, crackles, and hypoxemic. So he was started on some low flow oxygen and then put on high flow oxygen, had to be in the PICU. And then you can see the labs, there's a lot of neutrophils. All his inflammatory markers are high with elevated ESR, CRP, ProCap. And at this time, this is right during when COVID started. So our working diagnosis was, does he have some bacterial pneumonia? Is it COVID? Is this the MISC? So he was started on empiric antibiotics. And then, but what happened was his swabs for COVID 2 PCRs, a set of antibodies, everything was negative, and his viral panel was negative. So there's no infectious cause for why he was doing this. And we had thought of all these other differentials, which we, again, he didn't fit in. And then we did a urine tox as part of his workup, and then it was positive for marijuana. And then he disclosed that he had been vaping almost every week. And then, so a new diagnosis now was suspected EVALI. So we changed our management from COVID and acute like bacterial infections to EVALI, changed him to IV steroids. So the thing about this is the timeline. At the beginning of COVID, there was this confusion, do we give steroids or not to patients, right? So we are like, we wanted to prove, like if it was COVID, we were not going to give steroids, but if it was something else, maybe he'll benefit. So it was a lot of like discussions and then ruling out other diseases before we decided to give him some IV steroids. And then he really weaned to oxygen, to room air very fast once he was given steroids, and he was discharged home. So this is a very typical CT picture, and I'll show you some more. So just talking about COVID and e-cigarettes. I like this picture because, you know, she is following the rules, wearing the mask, but still continuing to vape. So during the COVID time, the increased risk factors for teenagers were, you know, they were at home or a lot of social isolation, depression. And so instead of getting vape products from retail stores, which have a sort of better quality control, many kids were getting it from the streets and from online resources. So that was the danger, because we had no control over what products, what extra things that they were adding in. And then there was also all this interesting online chatter on all these experts who were advocating for vape use, but also telling them, don't share your products, don't do these vape clouds, things like that, to protect yourself from COVID. But they really like marketed on the vape products. So one question was, are vape users more susceptible to COVID-19? And so there is data to show that. One is, with every 1% increase in the number of vapors, there was an increase in COVID infected cases and deaths. And then they did a survey of a younger age group, and they said the likelihood of COVID diagnosis, the likelihood of getting tested, and the likelihood of having more symptoms was all much higher among those who vaped. And then the other thing is youth behaviors. You know, everybody's together, everybody's sharing their products and cloud. So increased susceptibility to COVID just by exposure. There's also, I think the slide is getting cut off, like biologic data. So you can see that these brown spots are just indicating the number of this specific receptor. This is the receptor on our cells, the ACE2 receptor, which is where exactly the SARS-CoV-2 would like to attach. What they found is smoke, whether it's like cigarette or any nicotine or vape smoke, increases the number of these receptors. And so there's more likely for them to get COVID. And that's what, especially they're showing this happens even with a mint flavored compared to a mango flavor. So we know that they're more susceptible. Are they more susceptible to severity? Like, is the severity worse? And here you can see, compared to a non-smoker to a smoker, there is impaired mucociliary clearance, the increased permeability, because now you have more of these receptors to accept the SARS-CoV-2. And then also there's more inflammation. And so sort of like a hyperinflammation, which caused the cytokine storm, that sort of caused the MIS-C symptoms. So as I mentioned, it was a huge diagnostic dilemma earlier because the symptoms, clinical exam are often similar, inflammatory markers are high, imaging can be similar. In our centers, you know, as Mike mentioned, the disparities, and there is some racial disparities. COVID-19 patients were mostly African-American, Hispanic. EVALI was mostly in Caucasian. And many EVALI patients had mental health concerns. And this antecedent weight loss was sort of a very common factor that we found in many of our patients. With regards to imaging, so this was a pediatric cohort where they showed, this is a very classic EVALI imaging. You have all these like infiltrates. Something very specific is like the subpleural sparing. So you can see the black around the where the pleura is. That means that area has it's not really affected. And so that is something that's a sort of a differentiating factor for most of our EVALI cases. And these were the different types of findings. And then they also found, like, in later cases, they get this like reticular pattern, which is sort of similar to a fibrosed lung. But compared to, like, if you compare these images with this one, you can see this is the COVID-19 images. Like, so the more fluffy infiltrates, more peripheral this time, and then you can have some cardiac changes, and also, you know, here you see effusions. So a little bit different in where the imaging looks. And then this is MISC imaging, just worse features. And that's why these patients end up needing a lot more respiratory support. Just to finish this, so CDC has definitions on EVALI versus MISC. So earlier, you know, it took a lot of time to get our COVID results back. Now we have them pretty fast, so we are able to differentiate. But also, you know, a patient could be smoking or vaping more, and the symptoms could be exaggerated. So nowadays we're able to clearly, like, differentiate it and differentiate the way we treat each of these problems. This case, I hope I have time. This is a 17-year-old who has eosinophilic esophagitis. So basically inflammation of his esophagus with eosinophils that causes a lot of dysphagia, weight loss. This can also be associated with, like, some bit of airway, like atopic features. And a big issue that our GI colleagues were facing was, like, this unexplained weight loss. So, like, you can see this bad, significant weight loss despite all her treatments being like optimized, and extensive GI workup being negative. And then, so she comes in, as I mentioned, you know, they can have some airway reactivity. She comes in with more of a status asthmaticus type of picture, and requiring, like, the ICU treatment for asthma, needing continuous albuterol, IV steroids, and BiPAP. And then what was unusual about her CT scan was this bronchiectasis. Bronchiectasis is the dilated breathing tubes, sort of a permanent dilated breathing tube. So this is, so that's the thing, like, you know, vaping. So bronchiectasis generally happens in sort of chronic lung disease. And here we have a patient who, at that time, we did not know she is vaping, but, like, suddenly, why does this otherwise healthy girl have this bronchiectasis, and also these nodules that we are seeing? So here you can see this clearly, nicely dilated breathing tubes. And then, so to figure this out, we actually had to figure out, like, why is she having this? So we did a bronch on her. So as you can see, you know, this is so inflamed and red. A lot of bumpy things, that's called cobblestoning, indicating inflammation, sort of chronic to subacute inflammation everywhere, and then a lot of secretions. And this mucosa was also friable, because when we tried to suction for our lavage, it was bleeding. And interestingly, her cultures, you know, bronchiectasis most important causes infection, and no infections present here. And then she discloses that she's been using Juul 1 pod once in every, like, 3 days, along with some marijuana. So our diagnosis now changed to e-cigarette related bronchiectasis. So interestingly, we actually had a case series here that was published by my colleague Eric. 3 patients with anxiety, depression, presenting similar, and then this cylindrical bronchiectasis. So this is sort of a new presentation for e-cigarettes. And so she was treated with steroids. The antibiotics were to cover for any, like, you know, bronchiectasis. Those damaged areas do attract different bacteria, so to come there. And now she's closely followed in the pulmonary clinic. So, you know, so when we were trying to figure out our answers, we did rule out some of these common reasons why we see bronchiectasis in patients, and she didn't have any of these. Last patient. So he is like a kid who presents with 8 months of abdominal pain, and again, vomiting, 20-pound weight loss. So we couldn't figure out what was happening. And then his vape history was daily marijuana and nicotine, presenting now with acute respiratory distress, tachypnea, and hypoxemic to 60%. needing BiPAP, antibiotics, steroids. So, at this time, the diagnosis was he has EVALI. And what was also because his case was so severe, he's hypoxemic to 60%, they actually sent his cartridge to toxicology to check what is in the products. And so they found 30% marijuana, 66% vitamin E acetate. So this vitamin E acetate is a huge problem, severe toxin to the alveoli. And so that is something we figure out from our bronchoalveolar lavage. We can get this number. And he also had other multiple toxic inhalants. So this was his initial CT to start with. At this stage itself, he was pretty bad with the infiltrates, subpleural sparing, and needing so much of oxygen. And then what happened is after a few days, it just did not recover. And then you can see he has a huge right-sided pneumothorax. And here you can see it above also, and the lung involvement is extensive. So at this time, this patient actually had to go on ECMO because his lungs were not functioning at all. And then over time, so he was on, this is not that patient. I just got this image from Google, but but this was an EVALI patient. So developed bad pneumothorax, persistent air leak, needed ECMO. He got better and he was decannulated, but unfortunately got worse again, had to be recannulated. So this is like extreme case of EVALI needing an ECMO. And here this picture, what it's showing is, it's like basically there's no lung function. And so all your circulation you're doing through external. So, and then unfortunately patient worsened, needed to have a tracheostomy done, and was in inpatient rehab, and then is now on 0.5 liters oxygen. So, so just a previously healthy patient with such a bad course, just purely because of this EVALI. And then this is a case series that was published from like a international global collaboration, and they found these the nicotine was the most common problem. Kids had ventricular dysfunction. One of them even died. This was sort of a common imaging results, common symptoms. And here you can see the saturations are all low. And this one is showing this oil red droplets. And this was also a cool image. Whoever did this was brilliant. And it says, no, we cannot connect your vaping device to your ventilator. And so in summary, so EVALI can mimic many other pulmonary diseases, often causes a diagnostic dilemma. So the cases we discussed were eosinophilic pneumonia, airway reactivity. We saw how as CF physicians, we get so confused, like why is this picture not fitting? The problems with COVID-19 and EVALI, bronchiectasis and acute respiratory failure. So when, commonly we treat for asthma as an outpatient, we can do some antibiotics, but if the picture is not clear or our therapies are not as effective as expected, do, refer to us. We can maybe dig in some more history, or you can just ask the history about vaping and then help we can help the patient. And you can see, we do see some very interesting cases in pulmonary medicine. So if anybody is interested, or you can guide somebody to pulmonary, please do so. So this is my last slide. So we cannot force someone to hear a message they are not ready to receive, but never underestimate the power of planting a seed. So I like this one, and then that we're all in this together. So that's all I had. So I'm going to stop sharing.
Hi, everyone. Thank you so much, Dr. Gittleman and Dr. Paul. At this time, if you have any questions, please feel free to add those into the chat box for Dr. Gittleman or Dr. Paul, and we would love to take a few minutes to answer those for you. And then Dr. Gittleman had also added these slides at the end of the presentation for resources, as well as the wrap card vaping resources that we have available with Ohio AAP, and then additional resources for clinics, counselors, pharmacies, and then for parents and families. And all of these resources will be available on the slides that we send out, as well as the recording. And like the slide says, time for questions. So please go ahead and send those in the chat box. And then the Preventative Health Program has also created 2 new resources, one for families and one for physicians. And there will also be one translated into Spanish. You can access all of our resources on our website. Like you register for the training, and there's also information about the Quality Improvement Project on there. So everything that you'll need for all the trainings are on there. And then as a reminder, our next training is on September 9th, and you can register there. And then here's my contact information if you all need anything. It doesn't look like there's any questions right now. I'll still give it a few more moments, but if anything does come up, you can send me an email and I can shoot those off to Dr. Paul or Dr. Gittleman, and we can make sure that those get answered. And I wanted to thank them again for presenting, and also thank the Ohio Department of Health for their support with this project. And we're excited for the next 3 trainings of our webinar of the month series. I know that there's going to be 3 in September, but that is we had to kind of cram the last 3 into this month, but they will still all be great. Okay, thank you all for your nice comments. I will send the survey out to everyone tomorrow to claim your credit and get your certificate. And then we will see you all at the next training. So thank you all so much, and have a great Thursday and a great weekend. Awesome.
Thank you, Alex.
Yeah, thank you all so much. Getting a lot of great feedback in the chat box, so that's awesome.